Well, good morning, good afternoon, good evening, wherever you are in the part of the world you are. Welcome to our strategic webinar at Smile Digital Health. It's our Zen series, so it's meant to be peaceful, but to be honest, they selected two of the most disruptive presenters in this organization to do this. So we'll try to be as Zenful as possible, but no guarantee. So this webinar is called Zen Apollo. Apollo represents our February release. We go by release name by alphabets. But before I dig any further, I'll introduce myself. My name is Peter Yu. I'm a director of our Smile Labs here at Smile Digital Health. I'm here with my intelligent colleague, Chris Stolten. Chris, why don't you introduce yourself quickly?
Yeah, hi everyone. I'm Smile's Director of Architecture, so good to virtually see you. We'll be responding to questions at the end of the presentation. I believe there are instructions on how to submit those questions just below the live stream window. But yeah, good to see everyone, and over to Peter.
Thank you, Chris. So I'll give a little background story about Smile Digital Health, about our pattern on releasing our quarterly release. We like to go by alphabets. So we went from A to Z until this, and then the whole organization kind of went on a freeze, like, oh my God, there's only 26 letters in the alphabet. What are we gonna do? So what we did was we kind of went back and we did A for Apollo. And I personally felt this release called Apollo it's very unique, and I think I can relate a lot to healthcare. And I want to share some historical background for everyone. So 1903, the Wright brothers decide to build an aircraft, and the brothers were successfully to record a 12-second flight across 100 feet in North Carolina. The Wright brothers, and that's 1909. But do a quick math. In 1969, 66 years later, Apollo 11 landed on the moon. So think about the journey of we just were ground observers looking in the sky and became space explorers in 66 years. And that just shows, the human grit or mankind or just our humanity getting together, try to accomplish a mission. And it's quite fascinating if you kind of look at healthcare. Healthcare data interoperability kind of started, many decades ago. But we're all getting together as industries and everyone on this call trying to get together to get true data interoperability in terms of better global health. So I find this Apollo release name very meaningful, and I hope we will have the same trajectory as the success of Apollo 11. Okay. So I'm going to go to my next slide, which basically speaks to the agenda. Before that, actually, if you do have any questions, ideas, or comments, please drop them in the chat. If you are actually streaming from YouTube, there's a link in the description. I know the comment section in the YouTube is enabled right now, but we're not actively monitoring that right now. So please do sign up. You'll get email confirmation. Jump on our webinar app. There you can actually interact with us, post questions, and we can answer you and have a conversation at the end of our section. Okay, a glimpse of our agenda. You will get a glimpse from me at Smile Digital Health at a high level. I have a 3-layer onion that I'm going to peel, and I'm going to discuss that with you, and how recent Smile technical advancement will help your business, preview of Smile premium products, lessons learned from latest US regulations, which a lot of our payers are trying to figure out how to comply with the mandates, and we have some latest updates for the group. And lastly, we'll open up for Q&A for the group. So Smile Digital Health, this is our statement. We are preparing healthcare provider, payer, researchers, and life science organizations for a connected future beyond legacy system with the mission of better global health, landing on the moon. So what does this mean, right? In my upcoming slides, I am going to dissect this. I'm going to dissect how we can help each sector to create a more connected future with our solution for better global health. Okay, I promise that. So before we start, there are 4 kind of universal data truths that we believe in, and we strive to hit all these 4 quadrants. I'm going to start from the 11 o'clock, and I'm going to make my way around the clock. First, we believe in a single source of truth is a must. We understand from the data, from variety, there is an infinite amount of variety of data. There are some standards out there like the CDAs, the XL7V2s, the X12s, the FHIR, obviously, because we are in the FHIR business, but there are also other proprietary data models or local models that are created. So at Smile, we create a solution to create transform and ingestion to ensure that, and actually egress too, on both ways, to ensure that data is conforming to the FHIR spec, and we can transform that information to create a single source of truth. Then you actually have a 360 of a data set to do intelligent things with it and to do intelligent analytics with it. The second is the volume of data is growing exponentially. Fun fact for everyone. I did a quick search. In the 2020s, we are estimated to have a 1 zettabyte of data. I actually did not know what is a zettabyte. So a zettabyte is actually 1 billion terabytes. But in a few years, apparently, we're going to reach 100 zettabytes of data. So with volumes growing, healthcare data is going to grow proportionally, or even beyond the average proportion in terms of IoT, wearables, and a lot of other data sources that we're collecting from patients and from all the medical devices and all the things that we're collecting through clinical applications. So Smile have solutions to ensure that we meet those demand and that scalability. The third is data is a competitive advantage. And I would add more words to that. I would say good data is a competitive advantage. This talks about the veracity of the data, the truth of the data. How do we, for example, use master data management to get a complete person 360 of their information? Then you can truly drive insight, event-driven architecture to find the next best action once we get new pieces of information of this patient, because with more information, we have more insight, we can have intelligence, and we apply our clinical reasoning knowledge, and then we can have next best action. I'm going to talk about that later in a little bit. The last is data needs to be available to everyone. This talks about the velocity and basically how we're designed, right? This talks about using modern web standards and technologies like JSON, RESTful APIs. These are things that application developers can develop on top, and this is what Smile is built on top. We are making it easy for future proofing and also easier for individuals to customize and build their solutions on top of our Smile Digital Health solution. All right, this is the first layer of the onion now. So at Smile, our solution is our health data fabric. So we deliver an enterprise level FHIR data interoperability and data exchange capabilities. It's a product suite that's backed by a core capability of our flagship product, which is our clinical data repository, or CDR. In essence, with the Smile Health Data Fabric, you can implement it once and use it for multiple use cases. These are examples of solutions that we solve for different industries, such as improving population health, meeting CMS mandates, as well as addressing healthcare workout burnouts. Okay, so now let's talk about the second layer. So we envision a simple diagram. On the left, we have data producer. On the right, we have data consumers. We have many data sources on the left and many data consumers on the right. So it's a data orchestration pipeline, right? And on top, we transform, we enrich, we optimize the data. We make the data better for that complete 360, for better data completeness and data quality. And we derive insights from it. A lot of customers ask, okay, my data is in FHIR. What can I do with it? Our answer is we can derive intelligence through our clinical reasoning products. And I can talk about that a little bit later. So now on to layer 3. So on the bottom layer has transformed into 3 smaller boxes. It talks about data ingestion. This is talking about, data comes in very different variety, a single source of truth. Our ability is to use our transform, our syntactic transform from CDA, for example, into FHIR, V2 into FHIR, flat files mapped into FHIR, having these ability. And that's not just it. And Chris is later going to talk about our latest implementation of Camel, which talks about the flexibility of a routing framework that can allow our customers to route their messages in a way that they require before it gets persisted into the data management, which is the second box. and that is our flagship product. At the core of our flagship product does way more than that, which is the data persistent of a clinical data repository. And lastly, obviously, there's information coming out in, and there's information coming out, which can come out as a format of FHIR or other formats as bidirectional in other formats that it came in as. And at the top, we have transform data. And this talks about data optimization, talking about the data quality. And on the other side is talking about computation and government regulations. So focusing on the data optimization box on the top, this talks about our master data management. How can we have that 360 of information of a patient? And for data computation, this is using our clinical reasoning suite, using clinical quality language, CQL, is to derive insight directly from the FHIR server, directly from the FHIR data. No need to export information out. Work directly with the data that you have, because the data that is stored is conformed, is validated. You know the data is good and clean. And then through that, there's government regulations, because this is how we envision it. As data comes in, the data in data management gets optimized, and it also goes through data computation if you want. And this is the real-time event-driven architecture, which is maybe a new piece of information will trigger the next best action, the next notification that you need, whatever your solution is. And through that, this is how we see the flow is. The flow is then it goes in data management, in data delivery, and if we have government regulations like payer-to-payer, prior authorization, and other CMS regulations, this is where the data delivery will flow out into its appropriate data sources. Now on to you, Chris.
All right, thank you, Peter. Yeah, so every quarter, Smile have our official releases, alphabetically organized, as Peter has noted. Our most recent release of Apollo was Thursday of last week. I won't rehash all of that material, but I'll give all of you a brief overview of the last couple of releases and some of the major technical features added. And then we'll hand it back to Peter to discuss some of the really innovative solutions that have been layered on to Smile using those capabilities. So next slide, please. So in our Apollo release, several technical features, and I'll describe each of these in a subsequent slide. I'll describe how we've added a feature called server identity to watermarking. This is a very technical feature, but very useful in the event that an organization is pursuing or diagnosing any kind of data breach. Information was released to an individual, and then that individual posted it somewhere inappropriate, entirely outside the confines of the IT systems. This is a useful feature that can be used for traceability in those kinds of scenarios. I'll discuss a little bit about our advancement on our multi-tenancy journey and describe more about what that means. We've added a very useful new option for disabling resource version history. We've added, as Peter noted, support for Apache Camel, and we've got interesting on-rails support for clinical decision support hooks via our clinical reasoning module. And we'll talk a little bit more about that. So adding server identity to watermarking. Again, probably the most technical feature of the ones that I'm about to list here. But the idea here is that Smile is simply through enabling a setting can add digital watermarks to the resources that are released via Smile, and that feature has been enhanced. Those watermarks are by no means mandatory. There are no particular regulations that stipulate they must be there. However, for any of us in the health information management space, anytime an individual has to pursue a breach or an investigation, heaven forbid that happens, but logically speaking, if you work in the industry long enough, eventually someone is going to do something inappropriate. In those cases, this gives a lot of traceability. And so we have enhanced that feature, added in more information, not just about technical information about transaction identifiers, but information about the server or servers, plural, that served up the information in the first place. So that's a very, very useful feature when it comes to tracing through these types of incidents, should they occur. Multi-tenancy. So multi-tenancy is essentially in the Smile world when a single instance of Smile is representing data from more than one organization. And that could be different legal entities. It could be different departments or divisions within a single legal entity. It essentially means data in one system, but we need to keep that data separate, logically speaking. Many flavors of this, but as one can imagine, lots of scenarios in the healthcare information space where this arises. And so we have enhanced this. There used to be some technical restrictions about how patients could be identified across different tenants. Those restrictions have been removed, and that is a very flexible feature when it comes to, for example, our health information exchange use cases, other use cases about with organizations that cross different state or provincial jurisdictions or even different countries, and may need to represent the same patient or the same insurance plan member with entirely different identifiers for that patient in different systems. So again, a somewhat technical feature, but one the engineers are very excited about. This really does enable our health information exchange use cases. Okay, now a new option for disabling storing resource version history. That's a lot of words, but what that means in English, in HL7 Fire, when information changes, as it tends to do over time, a Fire server will create another version of the resource. So we'll create a patient resource called Peter U. 2 weeks later, a new Peter U's address will be updated. We'll create a second version of that same resource for Peter U, and so on and so forth. As you know, another 2 weeks later, Peter's phone number is updated. Peter's marital status is updated. Heaven forbid. I have no hint that this is happening, just an example. This is absolutely by design. This is an intentional feature of HL7 Fire. It allows the history of information to be preserved. There are some use cases where customers do not desire this. They find that this is inflating the size of their data storage, understandably. So for those customers, in cases where it's appropriate, one can disable resource version history. And what that essentially means is when a resource is updated and a new version is created, the old version, or versions plural, of the resource or resources will be removed from the system. Now, this is not something that's enabled by default, not because it breaks anything, but because this isn't appropriate in every jurisdiction. There are certainly some jurisdictions in which healthcare information must be preserved and cannot be altered. In those cases, this setting would not be appropriate, though an organization might perhaps turn it on in a pre-production environment for experimental purposes in order to reduce a cloud storage footprint or similar. But there are also use cases where organizations in their production systems are only interested in the latest version of information. And now we have that option. It was always available, but through jumping through some somewhat complicated hoops in order to remove old versions of the data. Now that can be done with a simple checkbox in the administrative portal. So very useful feature. Support for clinical reasoning, clinical decision support hooks, or CDS, on Fire. So this is quite interesting. Smile has had support for a Fire adjacent standard called CDS hooks for some time now, and we continue to offer that support. But it is in the past generally offered as what you might call a build your own, bring your own CDS hooks service that we expose some programmatic interfaces that developers could use to leverage Smile and integrate via this CDS hooks paradigm. That is all still available, but we have added a couple more options on Rails to very easily, including with non-technical members, non-developer staff, to create CDS hooks services for a couple of on-Rails operations that are very common in this clinical decision support space. I won't go too far down into the weeds, but of particular relevance to our prior authorization solutions, which we'll get into in subsequent slides. And last but not least, the integration of Apache Camel into Smile. So Apache Camel is, for the technical folks on the call, is something they may be familiar with. This is a very capable integration and orchestration platform. Smile has a number of capabilities already for incoming and outgoing data, transforming data to and from different formats. That is all still there. That is all very commonly used by our customers. We also have what we call an interceptor framework that allows custom logic to be expressed within Smile in order to extend the platform. But once in a while, especially with very complicated use cases, perhaps a state or national level health information exchange or other very large programs, or smaller organizations, but with very, very specialized requirements, there may be a need for more. There may be a need for a custom orchestration, and customers have been looking to Smile to expose a methodology in order to do that orchestration, in order to chain together a series of capabilities to add each of them onto the other. That has been possible in the past, but again, is more of a technical operation. It requires a little more visibility into the code, a little more custom writing. Leveraging Camel allows this kind of functionality to be added to Smile with less code, and by leveraging skill sets that exist out there in the industry. Apache Camel is an extremely popular platform out in the information exchange space, inside and outside healthcare. Comes with a wealth of connectors to a wide variety of data sources. This allows Smile to leverage those and build upon them essentially without reinventing the wheel. So we're quite happy about this feature. It won't be relevant to all customers. There are many use cases that are simpler than this, but one way that I like to describe this is anytime a customer asks Smile, can you integrate with X? The answer going forward really never has to be no. Really, we can make it happen. The only question is, well, how are we going to do that? Leveraging Apache Camel if it's not something that is immediately available out of the box within Smile. So a very useful capability. And that's a quick overview, obviously just the highlights of some of the most recent 2 releases of Smile.
Well, thank you, Chris. So now I'm going to talk about these advanced solutions. Upcoming, I got 2 advanced solutions and one that's currently available. 3 advanced solutions. These 3 advanced solutions that I'm going to talk about would be available in May or later this year. And then the other one, the 4th one I'm going to hit on is going to talk about an offering that is already in the market. And just want to draw some awareness to the group how awesome all these capabilities and all these products are. So the first I'm going to highlight is our clinical document architecture, CDA Exchange Plus. So the purpose of this is to centralize and standardize CDA ingestion to transform CDA documents into file resources while maintaining data provenance. That's very important. As we work with our customers, we understand a lot of our customers actually work with CDA data, especially in the CCD format. So and at Smile, we reimagine how can we do this and make it easier on the data stewards, on the administrators, and that's why we're proudly going to announce sometime in May, around May timeframe, we're going to release this premium module, premium product, Clinical Document Architecture Exchange Plus. And this will streamline the CDA ingestion process. It ensures regulatory compliance because there's provenance, the data stays true from a CDA format into FHIR. It's robust, it's scalable, it's performant, and also it's bidirectional. So whatever you put in Smile, what you get out, you're going to get the same thing. The second is master data management. So MDM has been part of our product for quite some time, but ease of use is something that we were always thinking about. So we're proud to announce that we're going to, in May timeframe, we're going to have an ease of use, a low-code, no-code approach to provide UI for our customers, for our data stewards to do the possible matches into match or no match, the possible duplicates into no duplicates, or it's a duplicate, so it can be deleted, and also configuring MDM rules. Sometimes scripting, it's alluding to Chris' point, sometimes, implementation can be complex. We want to ease that burden. So that's why we have this MDM UI to not only for data stewards to maintain the data, to maintain the high percentage of a patient 360, as well as on the other side is how can I configure these rules in a non-coder, non-developer way that I can start testing for better algorithm, for better match. As we look at our quite big clientele in terms of from a population size, 1% of better matching it equates to a lot of records, right? So we try to do our best to help our customers do this really well, because again, the data quality is very important. Good data is what people want. Remember the third leaf that I hit on? Not just data, but good data. This is our peer-to-peer solution. CMS does mandate a peer-to-peer. Chris is going to touch upon the CMS regulations in a bit. So this solution is talking about the requester side of the payer. So the CMS regulation does regulate, have a member-directed exchange now. As a member transfer from one payer to another payer, the health record or the claim records carry with them. So it's a direct exchange between two payers. On this regulation, there's less burden and less facilitation required from the actual individual, the members. But what we did was we started imagining, okay, on the requester side of the payer, how can we create a solution for them, a safe, secure, and an ease of use solution for them to request this information? So not only this is, if you think about it, we are helping our payers to meet the CMS mandate. Their experience with using this service, because it's something new to them in terms of this type of exchange, from a FHIR standpoint, make it easy for them and secure for them to do so. And lastly, as we know, again, going back to that people 360 record, the more information that's transferred is safer for that member, is safer for the population. So that is the better global health aspect of our payer-to-payer thinking as well. So now on the advanced solution that's available now, on my fourth one. So this is our Smile Digital Quality Measure. On this, you can see that's a QPP reporting. On this one, think about, for some of you or some of you that know that individuals and organization that has to do quality measurement reports, it takes weeks or days. Export the data, massage it, normalize the even data source, and then collate it and then report on it. What if I tell you there's an easy way to do it? If your data is in FHIR, and also in Smile, we have clinical reasoning sitting right on top, we can use CQL, clinical quality language, to drive these insights, to drive these metrics based on these cohorts. And through that, we can use an API to just submit these measures. Now it's actually in minutes. Once you define it once, if the measures don't change, it takes minutes, because the data, as it gets in the Smile, it's already clean. We already have the calculations embedded. We do the magic, we do the intelligence, the information gets sent. So this is once it's for reporting, but the other aspect is, how well am I doing, right? For these organizations, they can actually see real-time metrics. They can see, how can I do better? What am I doing not so good at? The other thing that's not on the screen is the care gap prevention. In my analogy, I'm going to hit an analogy in a bit, but care gap prevention talks about if we can make clinical knowledge computable, as in Peter at the age of X needs to have this scan, but my data shows I don't have this scan, or I need to do the scan by this. These computer logics can be in our clinical reasoning platform. With my data, if that's in FHIR, it can run through that logic as a batch or real time and figure out, Peter has a gap. I think we need to do something about that. And that's a prospective way of thinking about it. Most of the times right now, what we see in the industry is retrospective. It's too late. It's 6 months down the road, a year down the road. It's like, we should have done something. We could have got a better reporting. We got to have a better score. The patient could have been healthier, and there would be less healthcare spent. But because there wasn't a real-time mechanism to make it real time. So my analogy of this is actually, remember the car maps that you have in your car, that little thick book that you put on the side of your door, with before GPS, Garmin's, before your iPhone, before your Samsung, before all your smartphones. Think about that, right? I remember, as my parents would drive and then, try to read the map as quickly as possible, because one of these options will happen. Either your parents would just be like, I know my way, and they'll get lost, or you read too slow, you miss a stop, or you just completely give up because you don't know how to read the map. So this to me is my healthcare GPS, right? It gives metrics, it gives me direction, it tells me what's wrong, what's going to be wrong, and what I need to do to close that gap. So with that, It is powered by the latest technology and open standard, FHIR, our platform, Smile Digital Health, and clinical quality language in our clinical reasoning realm. And there's a QR code down there. Sign up for our educational webinar. Back to you, Chris.
All right. Thank you, Peter. All right. So a brand new set or I should say a finalized set of regulations from the Center for Medicare and Medicaid Services have now dropped. The formal name for these is CMS 3. You'll see us using those descriptions many times, really in coming weeks, months, and years, because these are going to drive a lot of interactions in the United States. So CMS 3, this is a pretty complicated set of requirements. They're going to be enforced January 1st of 2026 and 2027. Mostly the latter, but there are some administrative provisions that will take effect in the former, which I'll describe shortly. Now, these regulations, CMS 3, are really qualitatively quite different from what we now retroactively think of as CMS 1, which took effect July 1st, 2021 for our American payer customers. And those regulations, I mean, they were really spot regulations. They really defined a specific set of data that needed to be made available. End of sentence. There wasn't a lot of business application description tied into this. There wasn't a lot of workflow tied into this. It was simply, if you are a US payer, make this information available. Don't paywall it or otherwise make it difficult to access. And here's a couple of technical standards in which to make the information available. So it was certainly possible to achieve those initial mandates using what I'd refer to as spot solutions. Sometimes they'd be hand-rolled by an organization. Sometimes they would be a commercial organization that gave something that was, again, very narrow, specific, just for that exact use case. CMS 3 is different. CMS 3 is much, much larger. It is definitely an additive standard, that set of mandates that really layers on significantly more capability and requires much more complexity of interaction in a healthcare information ecosystem, in this case, one based on FHIR. So one could really think of the CMS 1 regulations as an early appetizer and CMS 3 to be the meal. Now things are really hitting, things are beginning to build out, and it's really important that we all collectively not think of these as individual spot solutions, because there is an interacting of information across different areas of the mandates that all begin to relate with each other and all require sharing and interaction using very explicitly defined standards in those mandates. So it's definitely a step up. I'm personally quite happy to see it. I'm glad to see that level of explicitness in the standard and actually business value being delivered by the standard rather than simply a foundational piece. But there's quite a bit of complexity to it. So what the new Center for Medicare and Medicaid Services announcement tells us. So there are, there is a mandate towards the implementation of FHIR APIs, and this applies essentially to all organizations in the US, all payer organizations that are CMS governed or CMS adjacent. There used to be in the original mandate some exceptions to this, but now one can see the full list, and it really is everyone. It really is everyone that touches on Medicare and Medicaid in some way, shape, or form. So that's probably good to see, because now there are no significant gaps and one doesn't have to consult a list to determine whether an organization needs to comply or not. If you deal with Medicare or Medicaid, you need to comply. Pretty simple decision-making process. There are several technical API requirements. So there is an update required to the patient access API, a small update compared to what was implemented for 2021, but an update nonetheless. There is a new provider access API, which is all about, well, payers sharing information with providers upon request, and again defines the format, the process around requesting permission to access the data. All of that is defined by the mandate. A finalized rule for payer-to-payer access. This is interesting because there was a proposed rule for payer-to-payer access 2-3 years ago. And the finalized rule, which will take effect January 1st, 2027, is different, not entirely qualitatively different as far as the outcome it's trying to achieve, but the method in which it does so is significantly different. So Smile has a solution there. We've described a little bit of about that in previous slides, but definitely a very relevant part of the mandate. And prior authorization access API. This is maybe the big fish in this particular pond, not to trivialize the others. Of course, prior authorization, electronic prior authorization as well, been around, have existed in the United States insurance space for some time now, implemented to varying degrees. The mandate, which takes effect January 1st, 2027, in this case, is a very, very specific method for executing electronic prior authorization that is, frankly, quite different from what most, if not all, organizations would have done before. It's a very sensible mandate the way it's written out. I can certainly understand the logic behind what it's trying to achieve, but it is not the same as how this was done before. It's surprisingly forward-thinking, and we'll get into that a bit in a couple of subsequent slides, but a real focus on burden reduction for the clinicians in particular, and therefore the patients, essentially, as a flow-through, really accelerating that decision-making process and leveraging surprisingly forward-thinking technologies in which to achieve that, including CQL, clinical quality language, which is again a FHIR-adjacent standard, an action language, a decision-making language to drive value out of FHIR data and make decisions and come to determinations. So, very, very powerful set of capabilities that Smile is very happy to offer. So, next slide, please. As I said, there are some operational provisions as well as the technical ones. I'll describe those operational provisions a little bit in the next slides. But most of the mandate does take effect January 1st, 2027. But we do want organizations to be aware, just in case they're not, there are some business elements the organizations need to do that take effect in 2026. Next slide, please. All right. So a few things. So prior authorization metrics. This is one of those operational provisions. Payers are required to publicly report certain prior authorization metrics annually, and they need to do that by March 31st, 2026. So that's, again, one of these operational 2026 mandates. This is not about electronic prior authorization or the way this is achieved. It's essentially a list of stats about how often prior authorization was needed with such and such an insurance plan and how often it was approved versus denied. Similarly, for individual prior authorization requests, there's an operational need to provide the denial reason. It's no longer enough to simply say no, never, not that that was ever a great practice, but now it is required to provide the specific reason for denial, if that is the decision. And very, very importantly, as part of the new electronic prior authorization mandates for 2027, there are now much tighter decision timeframes. Payers must send their prior authorization decisions within 72 hours, significantly faster than may have been the case in the past. In fact, Smile's electronic prior authorization solution will provide prior authorization decisions in real time if the decision framework has been encoded in the recommended pattern. But in those hopefully rare cases where that is not, and information has been cannot be electronically adjudicated and needs to be passed to an adjudicator to make determinations, the absolute grand total turnaround time there cannot exceed 72 hours. So that is quite interesting. Sorry, I should say that's for expedited requests. For standard requests, it's 7 calendar days, but in both cases, significantly faster than may sometimes be the case in the worst case scenarios today. All right. And what else have we learned from the new announcement? Well, I mean, we've a lot of the effects of the mandate, especially when it comes to prior authorization or payer to payer, do affect payer organizations. They are essentially the organizations on the hook, or the ones to which the stick is applied. But interestingly, the new announcement does also offer a carrot on the provider side, on the clinician side, and electronic prior authorization has been added as an item on the merit-based incentive payment system, or MIPS. So any US payer on the call now knows what that means. The demand for this is going to increase significantly. Certainly for the best. We can all see the benefit for this and the reasoning behind it. But that was always one of the aspects that I think people were curious about as the mandates were being fleshed out. It was clear there would be some enforcement mechanism at some point for the payers, but what would happen on the provider side? And here you go. You see it beginning to happen. And again, it seems to be occurring with carrots rather than sticks. That's fine, but it's occurring nonetheless. So very interesting to know. And we do have a nice, pleasant finalization of the standards and related HL7 Fire implementation guides, by which the various elements of functionality in CMS3 need to be mandated. So that's great. What that really means is that from a technical implementation standpoint, it's off to the races now. Organizations can go begin implementing this in concert with your partner Smile. Essentially right away, we can begin executing these, because now we know that the standard as defined is the standard that will take effect January 1st, 2027. It is now labeled as the final rule rather than the proposed rule or the interim rule, as was the case before. So we have certainly seen with that finalization a pretty dramatic uptick in interest from our payer customers, very understandably, now that organizations know it's real and know that there is a date attached. So that all is the very high level overview of the highlights from those new CMS mandates. All right. And of course, we've got a set of solutions here. There is the core Smile Health data fabric, and we do have two custom business solutions layered on that. One for payer to payer, leveraging the new mandate, and another for Smile electronic prior authorization. We're really happy about this. This is, again, as I described CMS3 as a standard that layers on capabilities onto what were just foundational pieces before that were there really for technical reasons. Now we're starting to see actual business value and business execution driven by these mandates and these standards. So we're really quite excited about that. We're also excited that organizations that have invested in Smile in the past, generally to use us to beat CMS 1 compliance, but sometimes for other reasons as well, are going to see value directly from that investment, additive value from that investment, not simply for that mandate, but for the future mandates as well. There is significant work that does not have to be redone, and the capabilities of the platform can be leveraged. This is not and has never been a spot solution for a single use case. It has always been intended and does facilitate additional use cases as a very capable standards-based data platform. So that's one aspect where we're selfishly quite happy to see the relative ambition of the CMS regulations, because we know we can show really differentiating value based off of that, and are excited to show that for our current and future customers. All right. And with that, I believe we are wrapping up the formal part of our presentation. So now it is time for some question and answer. I believe we've had a couple of questions, comments posted. Let's see.
So this is the first one for you, Chris.
Sure.
I'll combine both at once. Are any of your customers using your prior auth and or payer to payer within the hospitals and the peer to payer for the payers?
As of this second, No, because the mandate was finalized late 2023. We're fast. We're not that fast. I don't think anyone is. I don't think anyone has one of these payer-to-payer solutions, or I should say, one of these new style prior authorization solutions in place today, because the technical aspects that the mandate needed to meet were we have been keeping extremely close tabs on them, of course, and have been very active participants in the various working groups and CMS bodies that have driven towards these. But yeah, that's not enough turnaround time. And plus, since the mandates take effect largely January 1st, 2027, we have a limited number of customers who say, okay, let's do it now. And make it live 3 years before the mandate takes effect. We have many customers working with us now to begin these implementations in order to be ready for that mandate. But we do not have customers that are live with this, nor would I consider that a failing in any way. I mean, again, I repeat, this was finalized late 2023. So this is really hot off the presses, virtually speaking.
Second question for you, Chris. Do you have experience with CDS systems built on Smile technology being certified as medical devices in the EU?
Fascinating question. I don't believe we've got existing medical certified devices in the EU. That said, we actually do have the medical device, medical technology certifications in North America, and that is a non-trivial, or I should say, a very logical extension of that, should that be required for any given European implementation. It is certainly one of the, these clinical decision support services are certainly one of the things we're most excited about in order to see in the future. It is one of the most valuable ways in which to leverage the sort of the structural richness of FHIR data. And Smile does have a real-time event-based platform that can give both real-time or near real-time decision support enrichment of responses to clinicians or anything else in a care setting, as well as more asynchronous population-based digital quality measures and other kind of aggregate reporting capabilities. These are really all driven by CQL, clinical quality language, which we really see as the future.
Okay, Chris, another one that came from me on the side here is, if the technical mandates take effect in 2027, what lead time is required in which to comply?
Yes, great question. So I guess the answer depends on how much you like stress. How much do you enjoy stress? If you're like me and you'd rather this be nice and relaxed, I would certainly recommend this start sooner rather than later. In the case of the first mandate, which took effect again July 1st, 2021, we had customers meeting that mandate anywhere from 8 months previous to the mandate to 8 minutes previous to the mandate, depending on how recently they when they actually implemented. Some at the nearly the last second. This mandate for CMS3 is absolutely going to take more time. The technical aspects of the mandate, especially given how relatively packaged some Smile solutions are not as heavy as the business changes or the corresponding governance that may go with them, such as around the prior authorization process. I'll just give one example in the realm of prior authorization. Okay, it's all very well and good to say that Smile has a system, or any other vendor has a system that will execute prior authorization decisions in near real time. But where are the rules today? Are the rules consistent, or are the rules essentially adjudicated by the Mark I human eyeball and a dusty binder on a shelf that someone occasionally reviews, but mostly executes with their judgment. If it's the latter, then there is going to be a work item to encode these rules and put them in a consistent place. If a given insurance plan or whole payer organization, in the worst case, I suppose, has a bit of a messy process when it comes to these prior authorization rule sets. And that's nothing to do with electronics or rules. That's simply a business process maturation that these mandates are serving as a forcing function to. So, as one can imagine, that kind of change may take more time than the IT changes that are required. Now, of course, that's a bit of a Chernobyl scenario I described. I think most organizations will have a much better handle on their prior authorization rules, and therefore the process of electronically encoding them should be ideally much faster and smoother than that. We've got several methods to achieve that, but imagine if that's not the case, that of course that step has to occur first. So that's the biggest reason why I would certainly recommend beginning this engagement and speaking with Smile account reps soon as possible, sooner rather than later, because we definitely want to get a handle on that scope and any blockers, especially as they don't relate to technology, but may interact with the overall whole. So obviously not a one-size-fits-all answer, but if there's one takeaway, it's that this mandate is going to take more time in the business at payers than the original CMS1 mandate did. That's one statement I'm very confident everyone can take to the bank. It's more complex and it will have more business impacts.
Thank you, Chris. Since we're on this topic, maybe I'll add a follow-up question for you is, for payer-to-payer, for the 2027 rule, how is that different from the one that's a few years ago?
Yes, actually surprisingly different. So in at one macro level, the intent of the rule, which is essentially to share clinical information from and insurance decision information, or the output from one insurer to another when an individual changes plans, or the overarching organization that manages a plan, that intent remains. Certainly the intent is to give to be grease on the wheels of consumer choice. And that has not been altered. But the technical mechanism in which this is achieved has undergone actually a surprising number of changes. There's also been, frankly, a much better set of business rules defined about what the expected flow is as far as what decisions the individual current or former plan member needs to make versus what the insurance plans need to make and how that needs to occur. So most of that has been a clarification, but what it means as a bottom line is that the payer-to-payer mandate is surprisingly different from the proposed rule of a few years ago. So there, for some organizations that began going down that journey either as a home-built solution or leveraging something from another provider or from Smile, surprisingly little is reusable. I mean, again, that's not a technology failure. That is the regulations changed, not beyond recognition, but quite a lot between the two mandates. But that, of course, is the advantage of this mandate now being labeled the final rule. That previous one never was. Everyone was accepting a level of risk in building to a set of specifications that may not have been final. And yeah, unfortunately, it turned out they weren't. And the change was quite significant. I apologize on behalf of CMS. I didn't make the call.
Thanks, Chris. Well, I have one last question. I'm going to answer this one. I'm going to make it brief. Does your core platform have any AI ML capabilities? My answer is we will. Stay tuned. So follow us more and you'll learn more about it with the months to come. You'll hear about this domain and how not just this aspect, all the aspects of all the products we build. Continue following us. We've been doing a lot of great work, a lot of great products, a lot of great capabilities that we're pushing out for the market. So that's my answer. I think this is it. I think we're close to the hour. Let's wrap it up so everybody gets a few minutes break before their next call or next meeting that they need to head to. So thank you all.
All right.
Yes. Any final words for the group?
No, thank you very much, everyone, for joining. Thank you for listening to us. Yeah, despite Peter's intro, we were surprisingly non-disruptive on this call. I guess we behaved ourselves. But yeah, very, very happy to answer additional questions. Individuals at Smile, our account executives, representatives would love to speak with you further to explore your options here. And yeah, happy to continue with you on this journey in the healthcare information technology space.
Yep. As our favorite astronaut, Buzz Lightyear would say, to infinity and beyond. See you all.